Head and Neck Cancer Day. For today's discussion, we have an esteemed panelist and moderators for the parathyroid adenoma session. And I would like to invite the talk first by Dr. Neeti Gupta, and she will be speaking on the management of the parathyroid adenomas. Neeti, you can share your screen. Neeti, we cannot hear you. Are we audible or?
I can hear you guys.
Yeah, Neeti, now we can hear you. Yes.
Okay, great. And you can see the screen as well?
Yes.
Okay. Happy World Head Neck Cancer Day to everyone. And thank you again for this opportunity. Thyroid and parathyroid surgery is something which is very dear to heart. And I am so honored to have Dr. Cruz and all the esteemed panelists present. So let me begin right away. We're going to speak on optimizing surgical results for parathyroid adenoma. It's really intriguing how this small little gland, nothing more than 6 millimeters in greatest dimension, present close to the thyroid in the neck.
Neeti, I think there is some problem. I think sir just messaged that he cannot hear. Can I have a feedback from a few people if they are able to hear us?
Sure.
Again, maybe an issue.
Yeah, I think sir just...
Okay.
Okay, thank you.
Yeah.
Yeah, I'll try to speak louder. So what I was saying is it's intriguing that this gland, nothing more than 6 millimeters in the largest size, can have such far-reaching implications onto the body's physiological functions and can pose such great challenges in the diagnosis and management of their disorders. So, like we said, they are routinely 4 in number, present around the thyroid gland, generally 4 in number, but they can be supernumerary. They are about 5 to 6 millimeters in the largest dimension, weighing somewhere between 15 to 35 milligrams in weight, generally in an orange tan color. Now we know the superior parathyroid glands are about 1 centimeter area around the intersection of the RLN, right at the entry point where it crosses the inferior thyroid artery. And the inferior
I think there is some connection issues because I think she's having heavy rainfall there. Degree. Okay. Neeti just called. She's having some problem with the network, so she will log in once again later on. So we can start with the case discussion right now. Before that, Mukesh, are you there?
Yes, sir. Good evening,
Good
teachers.
evening. So I'll just introduce all the teachers. So we have Dr. Anil D. Cruz. He does not need any introduction. He has been my teacher in TMH and teachers to many, and teachers of all the teachers here as well. We have Dr. Arvind Krishna. He's a professor at DR Cancer Institute, Chennai. Dr. Gyan Chand, he's a professor and head at Lucknow. And Dr. Nina Irawati, she is a consultant head neck surgeon at Soitomo Cancer Institute, Indonesia.
Hi, Asim. Hi, everyone.
So Mukesh, you can please share your screen and start the case presentation. Sir, are you able to unmute yourself?
Just give me a minute, Asim. I'm changing locations. I'll be with you unmuted in 3 minutes.
Okay, sir.
You
Okay.
start. You please start.
Yes, sir. Arvind, sir.
Yeah, go ahead. I'm also there.
Okay.
I'm just sort of, reaching a particular place. You can go ahead. I'm able to hear you.
Mukesh, please start.
Good morning, all. Sorry, good evening, all. My patient is a 20-year-old man from Sonbhadra, UP. He is a student. He presented to our OPD with the chief complaint of swelling over the face on left side for the last 6 months, which was gradual in onset. Initially felt as a small smooth pulse, which slowly progressed to the presenting size, which was rounded pulse of about 3 finger width. It was uh, from the beginning, and there is also no history of preceding trauma. He seeked treatment at local center where he was given some anti-inflammatory. However, that did not relieve his problem. There is also no history of fluctuation in the size of the facial swelling. There was no history of restriction in mouth opening of the patient. There was no wound or any growth or lesion inside the oral cavity, and all teeth were normal. No loosening of teeth were there. There is also no history of skin changes like redness, puckering, or wound over the skin. There was also no history. Hello. Hello.
Yes, Mukesh, please start.
My patient who presented with complaint of swelling over the face on the left side.
Share your screen. Please share your screen.
Shall I now? Sir, can I?
Yeah, please proceed.
Yes. So he presented with complaint of swelling over the face on the left side for the last 6 months, which was gradual in onset. He initially felt it as a smooth balls, which slowly progressed to current rounded balls of about 3 finger width. It was painless, and there was no history of preceding trauma. He sought treatment at the local center, from where he was given some anti-inflammatory that did not relieve its symptoms. There is no history of change in size of the swelling during the course. He also did not give any complaint of restriction in mouth opening. There was no history of wound or growth inside the oral cavity. He also doesn't have a complaint of any tooth loosening or altered teeth. There is no history of skin changes like redness, wound, or puckering. There is also no history of any swelling in the neck. There is no history of any scalp wound. There is no history of any other swelling over the body. He doesn't also give history of any cough or hemoptysis. He doesn't have any history of abdominal pain or jaundice. There is also no history of any significant weight loss. He doesn't give any family history of cancer. There is no history of smoking, tobacco chewing, or alcohol intake. And he does not have any comorbidity like diabetes, blood pressure, TB, cardiac or renal illness. He doesn't have any prior history of prior hospital admission or any surgery in the past. So after taking history, we examined the patient. On examination, he was conscious, alert, and cooperative, of average build, and normal performance status. His vitals were within normal limit. He did not have any pyloric errors, sinuses, clogging, or edema, or any generalized lymphadenopathy. So coming to examination, local examination on inspection, there was a globular swelling seen over the ramus of the left mandible, about 4 centimeter, and overlying skin was free without any puckering, ulcer, or discoloration. And on palpation, it was a hard, smooth, non-tender globular swelling of about 4 into 4 centimeter over ramus of left mandible, with anteriorly extending 4 centimeter uh, 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 behind the angle of mouth, posteriorly till posterior edge of the mandible. Superiorly, it was 1 centimeter below the tragus. Inferiorly, it was reaching till angle of mandible, and laterally skin was free, and the overlying skin temperature was not raised. On examination of neck, there was no visible swelling in the neck, no visible scar, sinus, or fistula seen in the neck. However, on palpation, I was able to feel a swelling of about 2 into 1 centimeter in left parietal region that moved with the agglutination. And no any other lymph node could be palpated, or any other swelling was palpable in the neck. In oral cavity examination, there was no swelling, ulcer, or any other lesion. All teeth were normal, tongue, hard palate, uh, and buccal mucosa were normal. On Hopkins examination, oropharynx, hypopharynx, and larynx were normal, and bilateral vocal cords were immobile. On systemic examination, cardiac examination and chest examination was normal. and CNS examination, gross CNS examination was also within normal limit. To summarize my case, my patient is a 20-year-old boy with left mandibular hard globular non-tender smooth swelling of about 4 centimeter with another 2 into 1 centimeter left thyroid swelling without cervical lymphadenopathy. So I made a differential diagnosis of primary jaw tumor with a thyroid nodule, follicular thyroid cancer with mandibular metastasis, and third differential as parathyroid adenoma with Brown's tumor. So to diagnose further, I asked for investigation for tissue diagnosis, imaging, and blood investigation. So for tissue diagnosis, core biopsy from left mandible was taken, which was reported as fibrocollagenous tissue with areas of numerous multinucleate giant cell, and they gave diagnosis of giant cell granuloma without evidence of any malignancy. So imaging was done, PET scan was done. On PET scan, we found the metabolic lesion in the left mandible up to the coronoid, going down up the angle of the ramus, and another mild enhancement with low grade uptake was in the neck at the region below the thyroid. So, and it was reported as ASUB max of 9.38 for the left mandibular ramus lesion with cortical breach, and there was low uptake in sclerotic lesion in the skull. They also reported multiple tiny lesions in the vertebra and hypodense nodular soft tissue density posterior to the lower pole of left lobe of thyroid, measuring about 16 into 11 millimeter, and no other metabolically active lesion elsewhere.
Hi, Mukesh.
Hello, ma'am.
Sorry, it's Nina. Just wondering why you choose PET scan as the first imaging for this case?
Ma'am, my initial impression was one of the initial impression was follicular carcinoma with metastasis. So I
Okay.
wanted to. So USG neck was
1 minute. A follicular carcinoma in a young child. How common is it?
follicular carcinoma in 20 years.
I missed some of the history, but how did you make a diagnosis of parathyroid, and why do you think it was a thyroid? You have a patient with an expansile lesion in the jaw. Why
Yes.
did you do a PET scan? I must apologize. I missed a little bit of your presentation, how you made the diagnosis. Firstly, when you gave your history, I didn't even know where your swelling was. You said on the face.
Yes, sir. Left side of the face, over the middle.
As a doctor, when you present, you should be very precise. The examiner should know where the swelling is. So you should have said it's in the region of the jaw, in the region of the mandible, wherever it is. A face is a very non-specific area. And how did you, so this boy had this swelling in his jaw, which on imaging, what was the first investigation you did?
Sir, patient also gave outside he was investigated with CT scan, which also suggested a scapular lesion beside facial lesion. So we asked for PET scan at the first instant only. Beside that, I also had made my one patient as follicular carcinoma, sir. That's
No,
why we
not
asked.
on the CT scan. What was the provisional diagnosis? Did they say it was a metastatic disease? How do metastatic disease look on CT scan?
there will be, sir, multiple lesion over the multiple, can be at multiple sites, sir, with area of necrosis and hemorrhage.
No, my
And,
friend, my friend, the basic is metastasis to bones could be osteolytic, osteoblastic, or mixed. You cannot tell that you'll have hemorrhage and necrosis on CT scan.
Okay,
They're
sir.
either lytic, they're blastic, or they're mixed. This is a basic question that any exam will ask you. It's because you know the case. That's why you're making these fancy diagnoses. So on CT scan, describe your findings.
Sir, we did PET here, sir.
Okay.
CT, he had a report of CT scan outside, not the CT film. And
So even if it is a follicular diagnosis with metastasis, is PET the first investigation that you do? I have never done a PET in a suspected metastatic disease unless it's poorly differentiated. I don't know if the other examiners would do PET.
I agree, sir. I think unless you are suspecting any primary other than the thyroid, if you
And
had said that
in a 40-year boys' ages, and a candidate is saying his diagnosis was follicular CA with METs and he's doing a PET scan.
I think it's not acceptable.
I would send him back and call him after 6 months. Okay, go ahead.
okay, sir.
Okay,
So-
Mahesh, your first name is Mahesh, no?
Yes, sir.
So Mahesh, when you are giving a diagnosis, don't talk. I mean, we all make these mistakes as students. But please recollect in your OPD at Tata Hospital, has any consultant ordered a PET scan for metastatic disease in a differentiated thyroid upfront?
Sir, the first diagnosis what we get from tissue was giant cell granuloma. And
So if you have a giant cell granuloma, what's the differential diagnosis in a jaw tumor?
Giant cell granulosis,
If you see giant cells in a tumor in the jaw, what is your differential diagnosis in a 20-year-old boy? Okay, I will tell you. There are only 4. You should have prepared for this examination. I'm telling you what I read when I was a student. If you get a giant cell tumor in a young boy or in anybody, there are 4 differential diagnoses. Either it's parathyroid, it's a true giant cell lesion of the jawbone, which you get like a GCT. It's an aneurysmal bone cyst, or it's cherubism. There are only 4 differential diagnoses.
Yes, sir.
So will you remember this? Whenever you see giant cells which are hemosiderin laden, this is your differential diagnosis. And there's something you see very pathognomonic on the X-ray rather than adding a PET scan, and you should have done a serum calcium. Anyway, go ahead. Don't say follicular with METs, so I did a PET scan.
Okay, sir.
Okay, go ahead.
So after finding the lesion in the neck, US neck was advised, which showed a well-defined hypoechoic lesion of 1 into 1 into 3 centimeter, which was at inferior to the left lobe of thyroid gland and with significant internal vascularity. And it showed thyroid gland was normal and no other lymphadenopathy. So blood investigation was asked. It showed serum parathyroid hormone level of 855, calcium of 10.8, albumin was normal, create was normal, and alkaline phosphate was raised. It was 488. So after all these investigation, left lower parathyroid adenoma diagnosis was made.
Go back to your biochemistry. What's missing in the biochemistry?
24-hour urinary calcium, sir.
You could do it, but what else? What is very, there are 4 blood tests that you will always do to diagnose primary hyperparathyroidism.
Phosphorus, sir.
Yeah, where's the phosphorus levels here? What will happen to the phosphorus?
Phosphorus will decrease, sir.
Will?
Decrease, sir.
So you must put the phosphorus up, no? Do you do vitamin D?
Yeah, it was not available at this center. This patient is at Varanasi center, sir. And,
Anyway, it doesn't matter, my friend. Wherever the patient is, you are answering the exam. The Varanasi boys have passed and got their degree.
Yes, sir. I should have asked for.
So remember 2 things. Whenever you want to make a diagnosis, you will always do phosphorus. You'll always do vitamin D. In this case, your PTH is very high, 855. So it's more or less a clincher. But when you have PTH about 80, 100, 120, 140, always do vitamin D. Sometime when you correct the vitamin D, everything will return back to normal. And always see the kidney function, which you have shown us here as serum creatinine. Why do you do kidney function?
Because to rule out secondary hyperparathyroidism, sir.
Okay, good. Okay, go on.
And
so what? Excuse me, sir.
Yes.
So what biochemical picture you find in secondary hyperparathyroidism?
In secondary hyperparathyroidism, calcium will be low, so PTH is increased, and subsequently.
What about phosphorus? Sir is asking about the phosphorus.
In secondary hyperparathyroidism, sir, level of phosphorus will not be altered, sir.
That will be raised. Like in primary, it is down.
Yes,
in
sir.
Secondary, it is raised.
Mahesh, from Dr. Gyan Chand's question, if you're a smart boy, you should have said raise straight away. Nahi to examiner nahi puchega question.
Okay, sir.
Okay. Proceed.
Okay, go on. Don't mind if we get little hot with you, huh? We are just trying to teach you.
Yes, yes. So diagnosis of left lower parathyroid adenoma with branch tumor of mandible was made.
Acha, why do you say left? एक मिनट पीछे जाओ. Why do you? What is the meaning of this? अरे left lower दिखाओ. ये left lower क्या है? मेरे बुक में एक superior है, एक inferior है. ये lower कहाँ से आ गया?
Sorry, sir. I should have written inferior. Left inferior parathyroid.
How do you know it's inferior? Why can't it be superior?
In the location as per USC finding, they have shown at left lower lobe inferior to the left lower lobe thyroid gland.
So why can't the superior be there?
Superior, the location of superior is more or less constant.
So if I agree with you that the inferior is more commonly ectopic. Please tell me if the superior is ectopic, where will it lie? And what percentage of superior are ectopic? Nina, you want to answer? Asim, are other candidates able to speak as well?
So usually the person who is presenting answers, but others can also join.
Yeah, so if anybody wants to join, they can join. Okay, go ahead, Mahesh, you answer. Where is the Where is the location of ectopic superior? Okay, tell us, how will the superior migrate and where will the inferior migrate?
The superior, the ectopic site of superior can be anywhere between however to the location above the inferior thyroid artery only, sir. But inferior gland can have ectopic position retroesophageal in thymus, in mediastinum,
So,
and our superior parathyroid is
so it's very simple. The
Uh,
superior goes behind the recurrent laryngeal nerve. You missed Neeti's talk. Otherwise, you would have known these answers. And the inferior goes ventral to the inferior. So the inferior will always be in the thyrothymic ligament, in the anterior mediastinum if it goes. The superior, if it's ectopic, is usually retropharyngeal or retroesophageal. Gyan Chand, please correct me if I'm saying anything incorrect.
No, sir. Yeah, right, sir. Please.
Okay, ठीक है.
Sir.
Okay. Okay, so you should write that it's suspected to be the left inferior. Go ahead, Mahesh. And Nina and Arvind, please jumping whenever you want, because I'll keep talking and I don't know. Asim may not call me saying you only spoke, you didn't give the others a chance.
We love hearing your voice, sir, so that's fine.
Okay, go ahead.
so
But the thing
Well-
is, Mukesh, I just wanted to know, why did you say the diagnosis is a left lower or parathyroid adenoma?
with this biochemical finding, my diagnosis is parathyroid adenoma, and with USG finding, I made it as left inferior parathyroid.
So how do you know it's an adenoma based on these findings?
Uh,
Can you be sure that it is a solitary adenoma? And you can at best give a diagnosis of primary hyperparathyroidism. Possibly.
yes, sir.
Yeah.
Yes, sir. Possibly it can be multiglandular disease, but with only one dominant
Correct,
gland
correct.
adenoma, sir.
So I think while framing your diagnosis, you just say primary hyperparathyroidism and possibly likely a parathyroid adenoma solitary, or it could be a multiglandular as well, right?
With this diagnosis, treatment plan of surgery was made. Surgery was parathyroid adenoma excision, and on excision it was about centimeter adenoma, which on post-op histopathology was proved to be adenoma of the size 3.5 into 1.5 into 1.5 centimeter. So, and in post-op course, sir, post-operatively he was started on prophylactic calcium and vitamin supplements, sir.
My stop. We won't go to prophylactic and all. Let's ask you some questions. So here you have a young boy who has a hyperparathyroidism and a swelling in the jaw. My differential diagnosis is that it's a hyperparathyroidism jaw tumor syndrome. Do you agree or you don't agree? What is this hyperparathyroidism jaw tumor?
Hyperparathyroidism with jaw tumor syndrome.
What is the type of jaw tumor you get in HPT, JT? Hello? Am I
Yes, sir.
heard?
Yes, sir.
What is the type of tumor you get? Gyan Chand, is it a logical question or am I
Yeah, it's very logical, and lots of questions are, because this is a young patient along with the parathyroid adenoma with jaw tumor. So it's
And
very well.
he also didn't tell us whether he did any hereditary tests, some
Yes.
penetration. But I don't know, Asim, is this important for MCH? Maybe we're just troubling him a little much. Where is Asim? He's the
Yeah, sir.
internal examiner.
So we do get cases, but they need to be oriented by, and the reason we have been putting this session is because we were having regular meets with the endocrine department. And I had been attending them.
Yes.
I
Okay,
wanted you to come for this one.
Okay. Okay, no problem. Anyway, Mahesh, you read about the hyperparathyroid jaw tumor. You already removed the adenoma and you answered Dr. Arvind's question that it is possibly. How did you know it was an adenoma? Why didn't you do a 4-gland exploration? You have already gone to post-operative and started giving some post-operative. How did you know it was not 4 glands when you finished your surgery?
I could have asked for intraoperative parathyroid hormone, sir, to assess.
Describe what you'll do, my friend. You also did not tell me any other localization. You only did ultrasound and operated the patient. Is that correct?
Yes, sir. After PET ultrasound was done, and
what are the normal investigations that you do to image a parathyroid?
To image the parathyroid.
Okay, supposing I had not done a PET, I got a raised PTH, I did an ultrasound. Should I have operated the patient for primary or should I have done some other imaging? What are the imagings you do for parathyroid?
For technetium system, maybe scintigraphy is done, sir, to localize the.
What scintigraphy?
Technetium 99 system, maybe scintigraphy.
Technetium.
Okay. Any other tests you can do? System AB scanning. Any other tests you can do?
4D CT can be done, sir.
So which one should we do? Supposing we didn't do a PET, should we do 1? Should we do 2? Should we do 3?
Should we should do with two investigation, sir, with the mass, then that will give localization confirmation, sir. And with if ultrasound and system EB scan shows the localization at the same gland, parathyroid gland, then that is confirmed localization, and we can go ahead with localized exploration, sir.
So supposing I want to do 4D CT, why should I do a system maybe? When do you do 4D CT? When do you do system maybe? What are the advantages, disadvantages?
The sensitivity of 4D CT is high, sir, which is even in multi-glandular disease, the sensitivity of 4D CT is high, sir. So if 4D,
should 4D CT be the investigation of choice for parathyroid adenomas?
Sir, if available.
If available. Gyan Chand, would you agree with that?
No, sir. Actually, in secondary setting, suppose if you are operating in the recurrent setting, or if there is a small parathyroid adenoma which is not able to find on ultrasound and maybe scan, then you proceed for the either 4D CT, or even if you go for the PET, choline PET, not the FDG PET. In this scenario, the FDG PET was positive, so suspicion of malignancy is there. So in this case, you have to explore all the 4 gland. And
you already answered my choline PET question. एक question मेरा कम कर दिया. But anyway, Mahesh, please remember 4D CT is not the investigation of choice. The 4D CT, in my understanding, is only done for problem solving. As rightly Gyan said, ectopic, small, or you cannot locate it. Yes. Can you describe what is the meaning of this 4D CT?
this includes the differential enhancement of the contrast because parathyroid glands are highly vascular. These have a rapid uptake and washout time compared to the adjacent tissue, and hence.
So do I need a separate machine for that, or I can do it on my regular scan?
Sir, I have no idea.
Huh?
Sir, I don't know, sir. Sorry.
So what is the meaning of 4D CT? Sir is asking. Then you can answer.
This fourth is the this differential pattern which of rapid uptake and loss is good. Beside that,
So that is the timing of the
sir.
contrast injection. So if the machine you have a regular machine which is able to do the slice link like multi-slice CT, you can do in all these scan 4D CT. Just the operator dependent means operator, if the operator is timing the contrast and he see the washouts and all these things, so that you can very well appreciate these tumors. So that is the fourth dimension, is the timing. So timing of injection as well as the washout and those things.
Yes.
Mukesh, what is the principle of Sestambi scan? Like, how is it that these lesions tend to retain this?
Sir, the system maybe scan the half life of this is about 6 hours, sir. So there is and concentration is high in parathyroid gland and taken up by the mitochondria, and with this high density of mitochondria in the parathyroid gland will keep it for a longer time compared to the surrounding, and hence parathyroid is identified, sir.
Right. So it's taken both by the thyroid and the parathyroid, but the retention is more in the parathyroid. So delayed scan, you pick up the uptake. Right.
Yes,
So to answer your question, sir's question was, so you needed two localizing techniques which are concordant. Then you can go for
yes.
Yeah. And
Yes,
possibly
sir.
in this case, if you are suspecting or if the case is a jaw syndrome, don't you think you should have done slightly a 4-gland exploration?
Since we had, sir, ultrasound and it at the same mind, we could, but sir, the in 4-gland exploration, the chances of persistent hypocalcemia post surgery is higher compared to localized exploration.
Mahesh,
Yes, sir.
that is not the answer. The answer is, sir, I have done a biopsy on the jaw tumor, which was a classical Brown's tumor. In an HPT jaw tumor, you usually get an ossifying fibroma. You've done a biopsy, and the biopsy has told you it's a classical Brown's tumor, and he's got Brown's tumors all over in his skull, in his skeleton, in various others. 80% to 85% of these will be a single gland. So you have to tell the examiner, sir, I removed it. Firstly, I had a biopsy. It was not an ossifying fibroma. It was a classical Brown. I took out the adenoma. I had it returning to normal. And then you will have to discuss the various criteria. And that is why I did a single gland exploration.
Right.
You don't have to tell all this that the hypercalcemia is more and hypocalcemia is more. You have to, when you do 4-gland and when you do single, you should be very clear in your mind.
Okay, sir. We can also make this decision on intraoperative parathyroid hormone level assessment, sir.
Excellent. Tell me how you do intraoperative parathyroid, at what time points?
For pre-incision and pre-excision parathyroid hormone level can be measured, followed by post-excision at 10 minutes is measured. If the post-excision hormone level is less than 50% of pre-incision or pre-excision level, we suppose that the culprit gland is has been removed, and there is no need of exploration of all glands.
Nina in Indonesia does the blood test at 20 minutes. Is she foolish or is she correct?
She is correct, sir. This is another Rome criteria, sir, which also include the test at 20 minutes. And
So if name some more criteria. So what was the first criteria, 10 minutes?
First criteria at 10 minutes. Miami criteria.
Miami.
Okay, very good. So second is Rome. Any other criteria you know? How many criteria are there?
3 criteria, sir. The another one is similar to the Miami criteria, but
No, someone in the chat is saying Irwin's criteria. Someone else is saying Vienna criteria. They're saying there's 6 to 8 criteria. So which is the best criteria we should follow?
Sir, the Rome criteria is most specific.
So, but then why didn't you follow Rome? I thought Tata's goes for excellence. You have done Miami and you're saying Rome is the best.
There will be 3 times sampling to reduce that. Otherwise, Rome is most specific at 20.
See, you know the theory. You should not get panicky. You should be able to justify. You should be able to rattle out figures. How specific is Miami? When do you do Rome criteria? I do Miami very often, but I'm able to justify it. See, if you're going for exams, you should be able to justify. Like Dr. Arvind asked you about system EB. If you answer that it takes up system EB very, very rapidly, the examiner will ask you the next question, which will take you to the gold medal. Why does it take it up rapidly? If you don't answer him that question, he won't ask you. Are parathyroids mitochondrial rich? ये वो क्वेश्चन पूछेगा, गोल्ड मेडल हाथ में आएगा. तुम ऐसा ढीला ढीला बोलोगे तो पास करेंगे आपको. So justify your answers whenever you talk in MCH.
Yes.
So you please read the criteria. In the interest of time, we will not go over all the 6 criteria that are commonly followed.
Yes.
Okay. Other co-examiners, please stay over if there are any questions you all want to ask. I have to go back and scrub up in the theater.
Okay, sir. So
I'll
Mukesh,
wait till 6 o'clock. They've taken. I'll wait till 6. Please go ahead. Nina,
Yeah.
please ask something.
Sure, sir. Yeah.
Gyan, Arvind.
yeah, Dr.
Yeah.
Mukesh.
Yes, sir.
Yeah, so this is a young boy presented with parathyroid adenoma and jaw tumor. So what are the other familial hyperparathyroidism you know?
Familial hyperthyroidism, one can be, sir, familial hypercalciuric hypercalcemia.
Okay.
And second can be related to main syndrome, main 1 and main 2.
Okay. So good. So these are 4 main commonly like hypercalciuric hypercalcemia, and another is parathyroid jaw tumor syndrome, MEN 1 and MEN 2. So have you ruled out all this in your history of present illness?
Yes, sir. There was for main 2A, there was no thyroid lesion, sir, on ultrasound examination, and it as well, sir. And also, there was no signs of pituitary adenoma or pancreatic tumor in the pit.
Okay. And you know how to investigate all these familial hyperparathyroidism.
Yes, sir.
Good. So what is the management of hyperparathyroid HPT jar tumor syndrome?
Sir,
Extent of surgery?
the parathyroid parathyroid is operated for, sir, and for fibroma.
So would you operate the fibroma or not? And would your extent of of surgery differ if it is ossifying fibroma? That is in the parathyroid.
Sir, in jaw tumor syndrome, the fibroma part is also excised, sir, but I don't know, sir, extent of excision should be limited or.
Yeah, so in malignancy, like, HPT jar tumor syndrome have a higher chances of malignancy. It is a autosomal dominant disease. So in that case, either you do the subtotal parathyroidectomy or total parathyroidectomy with autotransplantation is the ideal choice. Otherwise, like in this case, if you did the selective parathyroidectomy, in that case, you have to be closely monitored to the patient for the recurrence. Because
Yes,
the PTH was very high in this patient and FDG PET was positive in parathyroid, large tumor. So HPT jar tumor syndrome, if it is there, so chances of malignancy is very high.
Yes, sir.
Okay.
Mukesh, do you know when we should remove thyroid when we're doing parathyroidectomy? Which case that we include thyroid as well?
If there are if it is biopsy proven carcinoma, then ipsilateral thyroid is also removed. If
1 minute. Biopsy proven carcinoma. Who proves biopsy in parathyroid?
Sorry, sir. If it is a suspected carcinoma of the parathyroid, then
that is the right answer. Then the examiner will ask you, how do you suspect carcinoma? Mahesh, actually, you are doing very well. You have to blame this Asim for putting this parathyroid. It's not a head and neck, it's an endocrine case. So we are troubling you because he has given you a tough case. Sometime in exams, it's just your bad luck. So very good. So Nina's question is, when do you remove the thyroid? Which is a very good question. So you said you'll do it in carcinoma. Any other place you'll remove the thyroid?
If, sir, on venous sampling, the site is localized, but I can intraoperatively parathyroid, culprit parathyroid gland is not localized, then in that case we can remove the ipsilateral thyroid.
No. Why? It could be ectopic in the mediastinum. What is intrathyroidal parathyroid?
That is also an ectopic position of the parathyroid, sir.
So then you will just remove it. If you don't see the parathyroid, you will operate the patient without localization and you'll go and do a thyroidectomy. Is that your answer?
If that site is localized, sorry, sir, I don't know other indication of thyroid.
So there are only two indications where you remove the thyroid. One is when it's an intrathyroidal parathyroid, and there are various ways of diagnosing it, but we won't discuss it at your level. And the second is when you have a suspected malignancy. Gyan, is there anything else that we need to do when we do thyroid with
Yes,
parathyroid?
along with the
Or-
parathyroid, if there is a thyroid lesion itself, suppose thyroid
Yeah,
malignancy,
yeah.
thyroid
So
tumor, multinodular
an incidental malignancy, or if you have like an ME and 2A and both manifest at the same time.
yes,
Yeah, but yeah, that's very, very rare.
yeah. But sometimes it papillary thyroid cancer
Yeah,
associated with
papillary,
the papillary.
absolutely.
Yes,
Yeah,
yes,
absolutely. I absolutely correct.
yes.
Asim, I'm going to sign off. Asim, I have to wash up in the theater, but thank you for having me. You did pretty well, Mahesh. I'm sorry, I'm a little aggressive
Yes.
as an examiner, but anyway, I always pass everybody, and for you, I would have given you close to a distinction.
Thank you, sir. Thank you so much.
Okay, bye, Asim. Thanks for
Bye.
having me on the program. Sorry to leave you all, but I had a rough night with the re-exploration. So my list is all gone, and I've got another webinar at 7.
Thank you. Thank you, sir. Thank you for
Okay,
joining with
bye,
us.
bye, bye, Asim.
Thank you,
Bye,
sir.
bye,
Thank you,
bye.
sir.
Thank you, sir.
So we can continue the discussion, and then we'll move on to the talk of by Dr. Neeti.
Right. Yeah, Mukesh, how do you follow up? You were mentioning about follow-up of these patients. No? How do you consider that as a cure? When do you consider a patient cured of primary hyperparathyroidism?
Sir, for cure, if the patient is monitored with parathyroid hormone and calcium in post-operative period, it requires supplementation. And if it is there is persistent level of parathyroid hormone level, then it is considered as residual disease, incomplete surgery. And if within 6 months after the 6 months with normal level of parathyroid hormone in between, if patient again has a higher level of parathyroid hormone level after 6 months, it is called as recurrent disease. So 6 months is the observation period to level it as cure or.
Correct, correct. Very good. I think say you're right. 6 months is the window. I think calcium is generally is measured, and in case it's a normocalcemic variant, then I think the PTH should also normalize by that time.
So Mukesh, can you diagnose it as histopathologically that whether it is malignancy or it is benign?
Sir, to distinguish it from carcinoma, we have metastasis, as that we don't have any data to this carcinoma from adenoma, sir.
Okay. So do you know any criteria for diagnosing
Carcinoma, sir.
any pathological criteria, because it is not able to diagnose if the adenoma capsular invasion is not there and though no metastatic lymph node was there. So how the pathologist has diagnosed? Did you know any criteria like pass score, pass score?
Pass score, don't know, sir. There can be histological finding like capsular invasion or high mitosis or with necrotic finding that would give us diagnosis toward the carcinoma, sir.
Okay, so there is a scoring system like in other neuroendocrine tumor also where you are not able to diagnose, like these criteria. So they have different criteria to diagnose whether it is suspect, whether it is malignancy or not. Because like Krishnamurti sir is saying, so during follow-up, you have to be careful, like in large parathyroid adenoma, you have to be careful, it may be malignant, so chances of recurrence and malignancy, metastasis may be there.
Yes.
So during follow-up, you have to be careful.
So
Yes.
clinically, can you suspect parathyroid carcinoma?
Uh,
Any clinical pointers? I know, I think as Dr. Gyan Chand said that the final diagnosis is only based on histopathological proof.
with parathyroid mass and with involved node or other distance metastasis that have as a carcinoma institute.
Again, somebody in the chat box has said, no, so your levels will be very high. So your PTH levels will be very high, your hypercalcemia, your levels will be high. You may have a neck mass. You may have some other symptoms, a large neck mass or something of that sort. So in those cases, you sort of, suspect. And in cases of the jaw syndrome also, the incidence of malignancy, as Dr. Gyan Chand was pointing out, no? And especially for the fact that this lesion, some of these lesions are picked. You said that there was an uptake in the FDG PET CT, right? So, which is so in some of these cases you suspect the carcinoma, right?
Yes.
So if you are suspecting a parathyroid carcinoma, so what will be your extent of surgery in that case? Suppose in this patient, if you are suspecting a carcinoma, then whether you go for the focused parathyroidectomy or what it will be your extent of surgery?
Then if there are no distance, no node, I will do ipsilateral hemithyroidectomy with parathyroidectomy and central compartment of the same side.
Good. So you have to go for the central compartment lymph node dissection along with the hemithyroidectomy on same side.
And what if you diagnose it post-operatively? So you've actually removed it, and post-operatively, I think your pathologist in this case say that there is a parathyroid carcinoma. Would you go ahead and reoperate?
No, sir, I will definitely not reoperate in absence of any nodal disease. I will observe or with close observation, sir, I will.
So generally, it's slightly rare. Sometimes what happens is intraoperatively, you find, that it is invading the adjacent tissues, and that's a general hallmark of carcinoma. So you would make that distinction or the decision intraoperatively to remove the thyroid or the other adjacent nodes and all those things. But I don't know. I think Dr. Gyan Chand, what is your protocol? How do you go about this in your center?
Yeah, actually, if you are suspecting peroperatively, you can send for frozen section at that time to check whether there is infiltration to the surrounding structure. Otherwise, if you are suspecting peroperatively, then you have to take it out. But post-operatively, if it is turned out to be malignant, then only observation for the calcium, like he told already that during operation, you have sent for the intraoperative parathyroid hormone assay. If it is turned down and you remove the gland, so that means cure at the time of surgery. But in the post-operative, if it is increasing, then you have to be follow and treat accordingly to the calcium level.
Yes.
Yeah, correct. So I think it's a slightly tricky situation if you get it post-operatively. Some people may say, go back, re-explore, remove the thyroid, the nodes and all those things. But again, I think there's no right answer to it. But as Dr. Gyan Chand said, you sort of, base your decision based on intraoperative findings and your IO-PTH values. Yeah.
So it was a tough case for him actually, because young boy with this parathyroid, large parathyroid adenoma with jaw tumor syndrome. So basically the examiners ask about the other familial things, whether it is man 1, man 2, and management of the different things. Then how you go for the genetic testing, how to do the genetic counseling, because in family history you have to ask the other siblings what is the status of other siblings and other family members also. So those things are important in this scenario, and management according to the disease wise. If it is positive for the HPT jaw tumor syndrome, then HPT jaw genes is positive, then you have to be assessed for the other family members, check for their calcium levels and PTH levels.
Yeah. What if it is MEN1, Dr. Mukesh?
If
Just hunting for questions, because I think each of these questions are a little tricky. But I guess considering the case, we are just forced to sort of ask some questions like this.
even if it is main one, sir, for such symptomatic parathyroidism, will remove the parathyroid, culprit parathyroid gland, and for if with associated pituitary or pancreatic disease.
So again, the thing here is the extent of surgery. Would it be a focused approach, or would it be a foregland or a bilateral neck exploration? That's the main thing to answer here. In a MEN1.
Main one present mostly with parathyroid hyperplasia instead of parathyroid adenoma. So,
so more chance of multiglandular.
sir.
Right. So you would sort of, try to
Explore
do explore all. And in case sometimes all these forearm auto transplantation and all are all there in the MEN1, right?
Sir, can we have the talk of Dr. Neeti?
Perfect. I think
Sure.
we are just asking him more and more questions. I think
Yeah.
And I think Mukesh, you've done very well. I think as I said, as the cruiser also said, the case was a little tough, but I think you really answered very well.
Yeah, he did very well and did good job. Thank you, Mukesh.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, Gyan Chand, sir. Thank you, Arvind, sir. And thank you, Nina. Thanks a lot. I'll request Dr. Neeti Gupta to please start her talk on optimizing outcomes in parathyroid adenomas.
Right. Hello, everyone. And apologies again for the technical glitch from my side before. Is my screen visible?
Yes.
Great. Okay. So, like I was saying, it's really intriguing how glands of such small size can have such far-reaching implications on our bodily functions and can pose such dilemmas in management that we're actually having a 1.5 hour dedicated session, but we're still not getting sorted on certain issues. We've already discussed anatomy. So the superior parathyroid glands are around a 1 centimeter area near the entry point, and the inferior are around a 1 centimeter from the lower pole. Of course, we know that everything about parathyroids is variable. So there could be supernumerary parathyroids, there could be ectopic parathyroids, the most common locations being retropharyngeal, parapharyngeal, along the thymothymic tract and into the mediastinum. But an interesting thing about parathyroids is they'll follow a bilaterally symmetrical anatomy. So the location of both superior parathyroids, right and left, will be constant, and so for the inferior as well. Another interesting thing about intrathyroidal parathyroids, we were just touching upon it a little bit. So embryologically, we know that the inferior parathyroid glands develop along with the thyroid. So you'll probably expect the inferiors to be more often intrathyroidal, but literature actually says it's the reverse. The superior ones tend to be more intrathyroid. Physiology, we know a low calcium level in the blood activates the parathyroid glands to secrete their hormone, that is parathormone, PTH. which then subsequently acts on the intestines to increase absorption, on the kidney and the bones to increase mobilization from calcium there as well, to maintain the serum calcium eventually. Now, coming to hyperparathyroidism, it could be primary because of increased production. It could be a single adenoma, a double adenoma, or a parathyroid hyperplasia like a multi-gland disease, or like we were discussing, a malignant hypercalcemia or a parathyroid carcinoma. Hyperparathyroidism could be secondary because of compensatory increased secretion, generally seen in chronic renal disease, but also sometimes seen with lithium therapy or GI absorption disorders. And lastly, it could be tertiary HPT, which is basically autonomous PTH secretion because of non-responsive PTH receptors, and it's generally seen in renal transplant patients. Symptoms, it most commonly afflicts women in the second or third decade of life, and we've often memorized these funny terminologies of painful bones because of calcium resorption, renal stones, that is nephrolithiasis, abdominal groans, it could be associated with peptic ulcer disease as well, sitting on the throne, constipation, and psychological overtones. But more often than not, primary hyperparathyroidism tends to be asymptomatic, and therefore there have to be very stringent criteria before we decide upon surgical candidature. The NIH has given guidelines for operating on asymptomatic patients, and they are as follows: less than 50 years of age, unable to participate in an appropriate follow-up, a serum calcium of more than 1, creatinine clearance of less than 60 ml per minute, and a T-score which is less than 2.5 at any site, or a previous fracture fragility. The workup includes a very thorough history taking, clinical examination. The diagnosis is more often than not clinched on biochemistry. The offending gland is then localized with imaging. Very rarely is cytopathology or any other investigation employed. So we were talking about familial syndromes. Now I'm going to come directly onto parathyroid adenomas because the discussion of these syndromes and secondary hyperparathyroidism is a lecture separate altogether. So parathyroid adenomas generally tend to be sporadic, but they could sometimes be associated with syndromes as enlisted below. We were discussing the HPT-JT syndrome. So according to what kind of syndrome, what kind of mutation and the coexisting features, you would do genetic testing. You would look for test the other family members and then accordingly decide about your surgical management. Coming on to workup, biochemical investigations primarily will be first to confirm the diagnosis of HPT. So serum PTH and serum calcium would be the clinchers, and other investigations would actually be used to rule out secondary causes. So kidney function test, urinary calcium excretion, because familial hypercalciuric hypercalcemia is a very, very common differential. So you need to do urinary calcium excretion and calcium creatinine ratios as well to rule out these causes and to confirm your diagnosis of a PHPT. Imaging or localization studies, so you'll do structural as well as functional imaging. And the first line is usually an ultrasound, which is a structural imaging, and a functional imaging in the form of a SESTA maybe. Other imaging such as 4D CT and the fluorocholine PET CT I'll discuss subsequently. Very rarely invasive tests like selective venous sampling may be required intraoperatively in case of a non-visualization of the offending parathyroid adenoma. Like we said, cytopathology is very, very rarely used, and often it's an inconclusive diagnosis. But you may do a guided FNAC, and sometimes doing a PTH washout on the FNA sample could yield a very high value, and that might in fact clinch the diagnosis. There's a lot of debate about what imaging modality is best. Routinely, we use two imaging modalities, the ultrasound and SESTA-MEB, and the concordance of these two modalities is utilized to narrow down onto the offending parathyroid gland. if you look at pooled estimates, the sensitivity of MIBI and ultrasound are comparable, though the pooled specificity might be slightly higher for SESTA-MIBI. This is a large meta-analysis looking at over 1,000 patients with SPECT being done as the functional imaging. And they found that on qualitative analysis, SPECT CT was better, of course, than SPECT alone. It was better at detecting single adenomas vis-a-vis multiglandular disease. And definitely the serum PTH, the calcium concentrations and the tumor size did have a correlation with the functional imaging results. Looking at the quantitative analysis, the pool detection rates per patient are and per lesion were around 88%. But there are certain limitations of the ultrasound as well as of the SESTA-MIBI. So the ultrasound, of course, is operator dependent. It may miss out on small or mediastinal and ectopic parathyroid adenomas. It is a little less sensitive for picking multiglandular disease. And there may be sometimes a difficulty in reporting on parathyroid adenomas due to concomitant thyroid disease. If you look at limitations of MIBI, like I said, it has some correlation with the severity of the hyperparathyroidism, like the calcium and the PTH levels. Vitamin D deficiency or the use of calcium channel blockers in patients might obscure findings. And so does the oxyphil cell content in the adenoma, because that is what the premise of the functional imaging rests on. And so to the rescue come 4D CT, which is the 4-dimensional CT scan. We already discussed the 4th dimension is the timing, the immediate uptake and the delayed washout of the contrast, and the fluorocholine PET CT. Fluorocholine PET is really revolutionized imaging for the parathyroid adenomas and has definitely demonstrated better sensitivity and accuracy than both MIBI and ultrasound, especially for ectopic lesions. This is another meta-analysis of around 272 patients, and look at the ROC. So the pool sensitivity and specificity for fluorocholine PET CT is very, very significantly high. This is a study that looks at 4D CT and fluorocholine PET head-on. And the results for sensitivity per patient and per lesion are pretty much comparable. Although fluorocholine does score over 4D CT when it comes to ectopic locations, a negative conventional imaging, and a persistent primary hyperparathyroidism like revision cases, as Dr. Gyan Chand had already told us. So this comes like a rescue investigation, both the 4D CT and the fluorocholine PET. Treatment we know is primarily surgical. So it's only the extent and the approach that is to be decided upon. Extent of surgery could be a limited exploration versus a 4-gland exploration. And the approach could be either an open conventional, open minimally invasive, endoscopic, or radio-guided parathyroidectomy. Definitely a minimally invasive procedure has the advantages of being less morbid, having less chances of post-operative hypocalcemia or recurrent nerve injuries, but conventionally has been shown to have more persistent disease, more recurrent disease, and in general, the proponents will say that it is at a risk of more overall failure rates. So let us really look into literature whether these conventional pros and cons are supported. Now, this is a meta-analysis that looks at bilateral neck exploration versus a focused parathyroidectomy for primary hyperparathyroidism. And if you look at the charts on your right, you will see that the cure rates are completely comparable. The p-value is insignificant. So even a focused surgical procedure will give the same cure rates as the bilateral neck exploration. And it will definitely have an advantage when it comes to complications. So lesser hypocalcemia, lesser recurrent laryngeal nerve injury is a definite advantage with a minimally invasive procedure. The earlier dictum was, do not remove anything until you have seen everything.
well, definitely the tides are changing. Another review looking at 12,000 above patients for a focused versus bilateral exploration. And if you see the rates of recurrence, the rates of persistence, the rates of overall failure, none of them are inferior even with a focused exploration. Although a focused exploration fares definitely better in operative time and overall complication rate. So we've established the safety and the efficacy of doing less than bilateral neck exploration surgery for primary hyperparathyroidism when you have a localizing study pointing to localizing studies pointing to a single offending gland. Having said that, the results would be most gratifying when there is a single adenoma. So every effort must be made to exclude a multi-gland disease or hyperplasia on localizing studies as far as possible. One must exclude the chances of a concomitant thyroid disease that might complicate matters. Irrespective, one must always counsel the patient to a more extensive surgery in case there are any intraoperative surprises, and the use of adjuncts such as IOPTH is paramount. Now, what if there is no localization? So a double negative localization, you've done 2 scans, you've done ultrasound and maybe both negative. Is unilateral neck surgery still feasible? So this was a paper where they divided patients into 2 groups. Group A had about 100 patients who had double negative scans. And just for the author convenience, they started exploration from the left side. If they found a possible offending or deceased looking operative parathyroid gland, that was sent out, that was excised, and IOPTH was used to see the response in the PTH levels, and then further surgery was extended to the other sides, like the left superior and the contralateral side. And they found that in up to 24 patients, they were able to do just a unilateral neck exploration, even with a double negative localization. What they found was surgical patients to identify very meticulously what looks like a diseased parathyroid was very important. And they felt that, so we've been discussing IOPTH criteria, and I'll come to that subsequently, of more than 50%, etc. But they thought more stringent IOPTH criteria, so 80% IOPTH criteria could help you to still get away with a unilateral neck surgery, even with a double negative localization. But to sum up the surgical management, you need results of 2 concordant localization studies. You need to be very, very aware of any previous surgical interventions that have happened before you plan your surgery this time. The disease status has to be kept in mind, including the severity of the hyperparathyroidism, and intraoperative PTH monitoring should be used. Eventually, what method or what approach is used is largely dependent upon surgeon and institution preference as well. Coming to approaches, again, you have open conventional, open minimally invasive, endoscopic, or radio-guided. Endoscopic and robotic parathyroidectomies will definitely have the advantage of lower pain intensity, lower analgesia request rate, a better cosmetic satisfaction, shorter scar, but it will falter with a longer learning curve, a longer duration of surgery, much like we discussed in open versus remote access thyroidectomies, and definitely more expensive. But fortunately, there were no differences noted in the conversion rate or the morbidity of the procedures, which is quite heartening. Now, this was a randomized blinded trial for for parathyroid adenomas with concordant localization. So video assisted versus open minimally invasive parathyroidectomies. So 30 patients in each group, and the primary endpoints were success rates and hypocalcemia rates. So the hypocalcemia rates are similar and the cure rates are similar. Definitely, there was lower pain and better cosmesis with video assisted as compared to the open. And there was the cost, of course, was more expensive if you do a video guided. Coming to the operative adjuncts, what can the surgeon rely upon when hunting these small little glands somewhere hidden in the neck? First and foremost is a thorough knowledge of anatomy. The parathyroid glands are often confused with fat in the central compartment, lymph nodes at level 6, and thyroid tissue itself. So I have taken the liberty to borrow this slide from Dr. De Cruz actually, and the beginners could use this as an indicator to differentiate a parathyroid from similar tissue in that area. But the all-important intraoperative adjunct is, of course, the IOPTH monitoring. We have discussed several criteria, but all of them rest on the premise that PTH has a very, very short half-life. 3 to 5 minutes is the half-life of PTH. So if you have a more than 50% fall at roughly 20 minutes post-resection, that is a reasonable guide to tell you that probably the offending gland is out and you may rely upon the adequacy of your surgery. So the rule is to first take a pre-incision sample, a pre-excision sample. So before, at the time of ligation of the feeder vessel to the adenoma in question, and a 10 to 20 minutes post-excision sample based on what criteria you're following. Either a more than 50% fall or a IOPTH fall for up to less than 40 picogram per ml are reasonably reassuring to for a lower persistence rate after parathyroidectomy. Only intraoperative visualization of a deceased parathyroid gland is inadequate to conclusively say that your surgery has been adequate. So this is a paper looking at more than 2,000 patients. And when IOPTH was used, they had a predictive, they had a cure rate of up to 98%, vis-a-vis just when the up to 87% when decision making was just based on the intraoperative parathyroid gland appearance alone. IOPTH is not very easy logistically. So very few centers have intraoperative PTH monitoring available, but it is a very, very worthwhile investment if you're doing these endocrine surgeries, as is quite evident from literature. We also practice something called sending out samples of the washings of the parathyroid adenoma. So you, after excision, you put the parathyroid adenoma in a little bowl of saline, hardly 5 ml of saline in it. And then you aspirate the washing from that adenoma and send that out for estimation as well. And very high values in that aspirate is also an equally good guide to tell you that you've done adequate or correct surgery. Lastly, a word about parathyroid autofluorescence. So we know that the parathyroid glands, when stimulated with near-infrared light, they re-emit significantly more autofluorescent light than the surrounding tissues like thyroid, fat, or lymph nodes. So ever since Paras and colleagues have elaborated on this particular quality of the parathyroid glands, it has definitely changed the way we look at parathyroid as well as thyroid surgery. And we have very high detection rates with NIR autofluorescence. How it helps is that it shows a bluish violet kind of a picture on the autofluorescence. Regarding the extra time necessary, we require hardly 3 to 5 minutes to prepare for the imaging system and another 3 minutes to visualize the parathyroid glands on each side. But again, it's a very helpful intraoperative adjunct. This was a paper looking at the patterns of autofluorescence when it comes to adenoma tissue specifically. And they saw that a heterogeneous NIRAF pattern was more predictive for an adenoma. If you had a cap of intense fluorescence in the background of a more heterogeneous autofluorescence, this cap is probably the normal parathyroid tissue that is seen. And this cap was present in nearly 85% of their parathyroid adenomas detected with autofluorescence. So the same cap you see over here, marked with ink, and is represented by this normal parathyroid tissue on histology vis-a-vis the adenoma. So may be theoretically useful for differentiating between adenoma and normal parathyroid based on the intensity of the autofluorescence as well. So surgery optimizing results is through a thorough biochemical workup, a good decision on surgical candidature, appropriate imaging, a wise utilization of the intraoperative adjuncts, and a good post-operative monitoring. Generally, the recurrence or the failure in the post-operative period is because of multi-gland disease. So sometimes criteria like the CAFTA score are used to identify whether you're dealing with a single gland versus a multi-gland. Again, some useful thing for MCQs as well as examination pointers for the MCH students. So pre-op total serum calcium levels, PTH levels, maybe ultrasound, and the concordance between the two, each are afforded 1 point each. And the higher the score on the CAFTAs, the more likely for it to be a single gland disease and therefore more likely to ensure a complete surgery. A quick word on mediastinal parathyroid adenomas. So you, of course, need a SPECT CT or a 4D CT for the imaging. Symptoms are the same. The superior and the anterior mediastinal locations are the most common, and surgery can be open versus video assisted. Another quick word on parathyroid adenomas during pregnancy. Again, like thyroid surgery during pregnancy, this is a very critical and a very important point. And although there have been no head-to-head comparisons and no statistically different distinct reports on the complication rates, surgical treatment is better than observation alone. You might consider conservative treatment if the ionized serum calcium is less than 2.75, so a mild to moderate hypercalcemia, and the low calcium diet or vitamin D supplementation and hydration would do. But if it's more than 2.75, surgery is the treatment of choice. You'll have to do ultrasound because radionuclide imaging will be contraindicated. And second trimester, of course, is safest, and you should have a multidisciplinary team when you're dealing with such critical issues. Last word on parathyroid carcinomas, we saw they're majoritarily sporadic. It presents as a neck mass with invasion of adjacent structures, so that should alert you. Biochemical features of calcium more than 14 mg per dl. Treatment is complete excision. So it may involve anything from a directed parathyroidectomy to a thyroidectomy with thyroid lobectomy and plus minus lymph nodal dissection. Where the disease takes you is the dictum. There is a lot of controversy about the role of adjuvant therapy, but because redo surgeries are extremely taxing in this field and has a lot of morbidity, there have been surgeons who are opting for an adjuvant EBRT, although again, the role is absolutely contentious. Surgical salvage is fraught with risks and usually requires some medical management of the hypercalcemia as well on the side. Predictors for success after parathyroid carcinoma would be, they've shown some pathological features that could guide you, which patients would require a more stricter follow-up and are at more risk of recurrence or metastasis. So a Ki-67 index, presence or absence of necrosis on your histopathology specimen, and the tumor weight are shown as known prognostic factors to detect recurrence or metastasis. Revision surgery, I hope you never need this, need to do this in parathyroids. So recurrence could be biochemical, structural, or frankly symptomatic. But the treatment algorithm still remains the same. Confirm the diagnosis, ascertain whether that is a surgical candidate depending upon the severity of the symptoms and the rapidity of the recurrence. Go ahead with appropriate imaging. And the success of the reoperation really lies in knowing the causes of the failure in the first place. So please go through the previous investigation details, speak to the surgeon, go thoroughly through the surgical notes, and invest a lot of time in counseling these patients, because this is a really, really challenging scenario. So with parathyroid adenoma, second chances are very tricky. Therefore, use your first chance very wisely. Go in with a very, very thought out surgical plan, extensive counseling, and make sure as far as possible you get it right the first time. Thank you.
Thank you, Dr. Neeti Gupta. It was an elaborate presentation, beginning with the investigations right till the surgical management and how to avoid redo surgeries. And if there are any questions, then they can be posted in the chat box. Or the participants can even unmute themselves. So if there are no questions, then I think it's time to conclude the session. And thank you to all the examiners, Dr. Gyan Chand, Dr. D. Cruz has already left, Dr. Arvind Krishna and Dr. Nina. Thank you for sparing the time on a working Thursday evening. And thank you, Dr. Mukesh, for a nice presentation. And thank you yet again to all our participants who make it a success every 15 days when we come on this platform. So the next session will be on 10th of August. That is after 15 days. We'll be back with another topic and another set of examiners. Thank you so much.